Subscapularis, as you saw, it's just quite a journey to get to this thing, okay? And what I'm gonna couple all this with is a little bit of, these are aggressive interventions. These are more targeted, specific releases. But when there's more serious issues happening in the shoulder, these are ones worth at least experimenting and seeing what the response is. Now you want to start more general first for a session or two before going after these. Pectoralis minor goes right from this bone, that coracoid process, attaches onto those ribs. So that's the problem with the nerve impingement pieces. Those nerves have to come out from the lower cervical spine, go underneath the clavicle, underneath pectoralis minor, and then down the arm. So trying to confirm whether or not the impingement's happening at the spine is, part of the journey and all that good stuff. But if it's soft tissue, like anything, defer to referral if you have to, all of that. But if it's been determined that it's not coming from the neck, right, then we know we can probably do some good work here. Old rotator cuff injuries can be part of the story. And it's just that in response to a major something happening here, a major entrapment, a major tear, a dislocation, a labrum tear, a lot of stuff, the response is going to be everything getting really thick and hardened down and guarding. And finding some way to mobilize all that. Now, supraspinatus can be worth targeting, but it's just this tiny little muscle. It has to go underneath that joint. It has to go underneath the clavicle and the acromion to attach onto the humerus. If somebody has something right here, you need to be a little bit careful because that injury and that pain can be related to the tendency to actually pinch that tendon between the head of the humerus and the acromion. And so repetitive overuse injuries, if the scapula is immobilized and stuck for some reason and not upward rotating when it should, then that humerus is more likely to cause that pinch, right? So if this is happening and I was kind of scared of it, then I would know at least if I mobilize the scapula and it can move better, then this action, they will get a few extra ranges of like a bit more motion, a few more degrees of range of motion without hitting that end point. There's also a bursa there that can get irritated. So just know that this right here is a rough place, and it's where most of the injuries actually occur. It can be from falling and getting jammed like that, or it can get torn from things getting pulled too aggressively. It is what it is for a variety of reasons. And supraspinatus, as far as the rotator cuff muscles are concerned, is the most common injury here, okay? Now, if somebody gets, this is the other one, is if they get taken too far back this way. Like in the sports world, it'd be like they're in defense and they get hit somehow like this. That's where usually a labrum tear or an injury even to subscapularis could occur. So the dynamic being is that ideally we're not dealing with this. If it's acute, be really careful. It's a bit more common in our journeys, as far as at least mine was, to find somebody that has had a bad injury here years ago, and now they found their way to you. And now it's all thickened down and everything's kind of just messy. The scapula is kind of stuck. The glenohumeral joint might feel a little stuck. It all just needs to be freed up. But the deep ones, and neither of these feel good, okay? There's no making pectoralis minor or subscapularis release feel good. So my statement to you is be honest about that, but also if you're gonna do it, do it. If you're gonna put somebody through it, make it actually worth their time, right? Don't be so scared and cautious that you're just pinching their skin and then they're like, I think that was a subscap release, kind of a deal, right? So that one's not too hard. All of you have been probably lambasted enough by me to know how to find that. And you might, if you're working on pecs, might as well get pec minor a little bit. And then you just need to get a bit more targeted here for that. And the action, and usually enough, has to be the scapula. It's this. Real small. So yeah, rolling this around works good, but if they kind of just roll their shoulder up into you, that tends to be what will shorten pec minor, also be the position of ease and make it more gentle. Subscapularis is the internal shoulder rotator. So quick review on the rotator cuff muscles. What they're predominantly about is just holding your arm on. So on top, supraspinatus, holding it up. Teres minor and major. Teres minor is the only one that's actually part of the rotator cuff, but it's counterbalancing supraspinatus. And then the rotators, supraspinatus, subscapularis, subscapularis, infraspinatus. Now they do this and they come all the way around and hug that humerus, and that tendon can get irritated. So Logan mentioned one of the referred pain patterns for a subscap is when people kind of point here, right on the anterior side of the shoulder, say something here, right? But you can't find it surface. You work on deltoid and other stuff like that. You can't find it. It can be a referred pain pattern from subscapularis, creating a sensation outward and anteriorly. So that usually is kind of a dead ringer for all of that. Now to get to this, since it's an internal shoulder rotator, where I position the arm is going to be bringing it all the way over, shortening that space as much as possible. That'll bring the scapula out and allow me to get under it, because that's your ultimate goal here. I'm trying to get my fingers between the scapula and the ribs. And two benefits occur here. Either we're getting pressure on subscapularis and reducing its tone, and people are usually going to be more dominant in internal rotation anyway, so it being released is a good thing. Maybe helps infraspinatus function more efficiently. The other big benefit, I think, is when we do this, is we're a wedge between it and serratus anterior, and we're doing a deep fascial release of separating those muscle compartments. So I think that ends up being a big secondary bonus here. To start with, what I suggest for safety reasons is not to aim in such a way where you're going up into the armpit, okay? But to try to be more inferior down here, down in this lower aspect of the scapula. Start down there, and then you can let that guide you to go a little bit more superior, but start down here just because it's way safer for you. It's almost impossible to hit the big tubes then. But if you just go, then you have to really know your anatomy, something special, and you have to be way more cautious. So start down here, and if we bring the arm over like this to start, I guarantee you'll find it more easily than having the arm up and out like that. After you get good at this, then you can get braver. But get good at the simplified, safe version, and then let that guide you to going further up. It's going to be the same thing if you saw psoas, where I say start low, get good at making sure you can find it there, and then you can change your orientation and go more superior up near the belly button. But it's silly to just go to the hardest, most dangerous spot first. No? Yeah? Good. The other one I'm going to sprinkle in with all this, don't worry, you'll be able to remember it because you'll see it all in real time soon, is the clavicular joints. So sternoclavicular joint, that's sternum, clavicular, sternocleidomastoid, okay, attaches there to here. You can see how that's a problematic story for a lot of people. The acromioclavicular joint is the more common one to have problems. This is the one coupled with other issues, but when people can't get their arm above 90 degrees in abduction. That tends to be a part of the story. If for no other reason, now maybe it got rotated and jammed, because this skeleton lets me show this. If that clavicle gets oriented and stuck, then it's going to limit the ability for that scapula to move appropriately, because it's just going to hard stop against the ribs there. So it can get stuck here, it can get stuck here. This one is the most common one, and it's the easiest one to interface with. This one you have to be careful that you don't choke somebody, because you're right by the esophagus, right? So this one though, we can stabilize it pretty easily. Now, I prefer to do this in supine, but you could do it in other positions. But the idea really is just to get your fingers in such a way where you're a little bit in between the acromion and the clavicle. I don't gotta dive really aggressively down in there. I don't know, to be honest with you, if I think that it's as much about really forcing the clavicle in a particular direction. I think if we really stabilize that joint and create a lot of force right here while a person's doing the movement, that their active movement is going to get that joint lubricated and it'll shift naturally. And we're just creating some artificial stabilization here while they bring their arm out to their side, push through some resistance, and if that needs to shift, it tends to just do it naturally. So that's what you'll be seeing with the acromioclavicular joint one. The sternoclavicular joint one, I can do it this way, or I could sit and use my thumbs. But like anything, I kind of go, this one I understand you need to be more careful, and it's worth like palpating and being used to. Even if you apply some pressure here and have a person go into flexion patterns, maybe that's beneficial. But the way you can be certain between the two is the sternoclavicular joint is more related to just shoulder flexion, okay, sagittal plane. Acromioclavicular joint is about abduction. So if a person comes in and they're like, yeah, that one's okay, it's not great, but then they show this, you know it's more this one. And more often than not, it tends to be, again, that one. So what I would do a lot of times would be a little bit of all of it and see what happens. So we'll start with the unaffected side.